Good morning, everyone. My name is Dr. Farah Nashi. I'm a neurologist working in Luxembourg, and I'm also an EAACI junior member representative of primary care and allied health section. Today, we have the pleasure to host Professor Omer Kalayci, who is a professor of pediatric allergy, and asthma in Ankara in Turkey. He's a senior author of an article recently published in Clinical and Translational Allergy Journal, CTA journal. Good morning, Professor Kalayci, and thank you for being here with us today.
Good morning, and thank you very much for inviting me for this interview.
Thank you. So the article we are going to discuss today is a systematic review about genetic association of the response to inhaled corticosteroid in asthma. So, Professor, there are still asthmatic patients that do not respond to inhaled corticosteroid. What is the role of genetic variants in this differential response?
Well, it's well known that a lot of patients with asthma do not respond to inhaled corticosteroids, and people treated with inhaled corticosteroids for 8 to 12 weeks fail to respond with a change in FEV1. Furthermore, people treated chronically with inhaled corticosteroids, 10% of them still continue to have symptoms. So what's the reason for that? Well, there are numerous reasons for that, which is very well known to everybody. Psychosocial problems, compliance with the prescribed medication, wrong technique in using the medication, noxious environmental stimuli that, affect asthma highly negatively. But in addition to these, there are also genetic factors. Several authors have suggested that variance in the response to inhaled corticosteroids, almost 70% of that may be due to genetic variance. But this is not easy to discover for many reasons. Well, number one, we're not talking about a single gene disease. We're talking about a complex genetic disease, which means that there are small variations in many genes, and even more importantly, these variations, the important ones, are the rare ones probably. And these genetic variations interact with each other, and they interact with environment, and they culminate in the disease phenotype. So now we're not talking about the disease itself, we're also talking about the response to a given treatment, which brings another player. So the response to treatment into this equation, which makes it even more complex. But the short answer to your question is the genetics play a great role in the variation to the response to anti-inflammatory treatment in asthma, but this is very difficult to detect.
Thank you very much. This is very interesting. So in this paper, you provide a summary of recent pharmacogenetic studies on inhaled corticosteroid. Some of these studies were genome-wide association studies, and others were candidate gene studies. Can you please explain your methods?
Well, genome-wide studies, we have included all the genome-wide association, GWAS, so-called GWAS, in our analysis. There are only a bunch of them, like 7 or 8. And then we have included all the replicated candidate gene studies. But GWAS is a powerful tool in doing genetic studies. The first GWAS was published in Nature, I guess, in 2007, so more than 10 years ago. But then afterwards, if you look at the association studies of asthma, I'm not talking about the pharmacogenetic studies, by the way, the two biggest consortia, Eve and Gabriel, they have included more than 10,000 patients, because that's the number that you need to reach the necessary power in these studies. Now, as I said before, when you talk about genomics, then you bring another thing into the equation, another variable into the equation, which is response to a given treatment. So when you do a GWAS with inhaled corticosteroids, you have to have really big numbers. In addition, you have to have data on the response to inhaled corticosteroids, which is very extremely difficult. In one of the largest studies done to date on pharmacogenomics of inhaled corticosteroids. There were 2,600 patients from 27 countries, something like that. And none of the SNPs that were discovered reached genome-wide significance. So there was nothing in the end. As for the candidate gene studies, we picked all the studies that were reproduced at different times by different investigators. But there's also a significant problem with candidate gene studies, because the results that you get in a population may be totally different than what you would get in another population. For instance, GLCCI1, there's a certain SNP there, and that SNP is associated with a positive response to inhaled corticosteroid in one population, but the association still exists, but in the opposite side in another population. And in one of our studies where we have looked at the response to inhaled corticosteroids and done genetic analysis on this was a candidate gene study, and GLCCI1 was not associated with the medication response in any way whatsoever. So that's just like the studies in the association studies. This is the same problem. The most consistently replicated SNP is in the Fc epsilon R1, so R2, low affinity IgE receptor. That's the one that's most frequently replicated gene, but still, there is nothing that has been consistently proven to be associated with inhaled steroid response.
So in our daily practice, how do you think we can take advantage of these results? Which patient will you target to go on with genetic investigation? And to finish, how do you see this field of genetics and biotechnologies going in the future?
Okay, this is a very interesting topic, of course, but we have a long way to go there. My mentor in the U.S., Jeffrey Drazen, once showed this slide at the end of we were interested in pharmacogenomics then, of the leukotriene receptor antagonist response. And the slide was a quotation by a famous Danish poet and philosopher. And it said, "Problems worthy of attack prove their worth by hitting back," which is exactly what this pharmacogenomics is all about. But I'm hopeful for the future, but there are a few things that needs to be done. First, one single center or for a couple of centers, it's impossible to reach the necessary power. So international consortia are mandatory to find a significant finding, to reach a significant finding. Well, for this purpose, I know there are two consortia that are working now throughout Europe, and we hope that, and then whatever is discovered should be, these candidate gene studies, GWAS, and functional studies should not be evaluated separately, but should be a part of a single approach. And then I think, I'm hopeful about what's going to happen in the future, very hopeful. And one really interesting approach would be if any gene or genetic factor or whatever can be discovered, then it can be used for prediction of the disease before clinical picture is fully established. That would be very interesting. In addition, in the field of pharmacogenomics, maybe those children can be treated before the disease phenotype is fully established. I think that's very exciting, but we have a long way to go there. I'm not sure if I will see that within my lifetime, but of course I do hope that.
Thank you very much, Professor.